Hi, everyone. So we're all awake and ready for a new item on OASIS-C2. Welcome again. My name is Ann Olson. I was very grateful for Mark's nice introduction. I am the other Ann with Qualidime. There's actually 3 vice presidents that are named Ann in Qualidime, just an important fact that I figured you all wanted to know. But I'm thrilled to be here to talk to you about the new item, GG0170C. As you've heard today, this is a new measure that is a covariate, and that's a popular term today, that does impact the quality measure for percent of patients that have pressure ulcers that are new or worsened. So what we're going to be talking about today is really demonstrating a working knowledge of this new item. I'm sure you've all heard about it. What is it? GG0170C, mobility. This is talking about moving from lying to sitting on the side of the bed, which is not new for any of us in home care. It's just a new measure, and we're going to be talking about really the intent of the measure, how to interpret the coding options for GG0170C, and then apply those instructions as Ann ended her presentation. It's so important that you leave here today with action steps so that you can instruct your staff. So that is our objective, is that you will leave with that information following the presentation. We did want to clarify, and you've heard Ann mention several times about code and coding. We just wanted to clarify that in home care, we talk about coders often about our ICD-10 coders, those very special people that have that training in ICD-10 coding. We are talking, as I think you all know, about scoring the OASIS, so the word code and coding is synonymous with scoring. So we talked a lot about the quality measure covariates. Both Nicole Keene and Ann Spinard talked about covariates, that they are one of the 3 risk adjustment types, and that they are patient characteristics that affect a certain outcome for our patients. And the items that you see on the screen here, Ann Spinard mentioned these, M1028, which is active diagnoses, 1060, height and weight, and 1620, bowel incontinence. Those are 3 covariates that my colleague Kathy Roby will be speaking to later today. And we're going to be talking about the 4th, which is the GG0170C, lying to sitting on the side of the bed. So you all know this is a new item. I don't know if you've all found it in the OASIS. I just thought I'd orient you that it is in the ADL's IADL section, and found in between M1850, which is transferring, and before M1860, which is ambulation and locomotion. And the item intent. So we read specifically what GG0170C says, which is it identifies the patient's need for assistance with the mobility task of moving from lying on the back to sitting on the side of the bed with feet flat on the floor with no back support. So that's a real formal way of saying what we do every day in home care. We go in and we always want to assess how is the patient at moving from a lying position to sitting on the side of the bed and safely sitting with their feet on the floor. That's something that we've been assessing for years now. But what's important, that this is a new measure that's going to help us to quantify this, and one of the Impact Act measures that we've all talked about, so that we're going to have a consistent way of identifying the patient's ability to perform this task, and whether they can do it by themselves or whether they need assistance in doing that. By using this measure, and again, this is across all settings, as the other speakers have talked about, we're going to have the uniformity of this data. It will have that interoperability that's so important. and also this whole covariate piece, so that it's really looking at how does the patient's mobility impact the risk for pressure ulcers that Ann Spinard spoke to earlier. So the rationale, I think, has been talked about, and we've all heard about in nursing school for many years, and in our experience, that it's no news that immobility can lead to a higher risk for pressure ulcer. It can adversely affect wound healing, and it also can increase your risk for development of pressure ulcers. So obviously that's one of the main reasons why we're looking at GG0170C. And what time points is this? I'm sorry, I didn't push the button, sorry. So what time points are we completing this? We're doing this at the start of care, which, as we all know, is within 5 days of the start of care date. And we're doing this at the resumption of care, which is within 48 hours of a return to home after an inpatient facility discharge. So how do we complete this? How do we obtain this information? What are the steps for the assessment for GG0170C? The first, obviously, is to observe and assess the patient's ability to do this. This is our greatest skill, one of our greatest skills in home health. So have the patient perform the task. We also want to get as full a picture as possible, so obviously ask the family members or the caregivers, how does the patient perform this task? So you're pulling all of the information together to assess what their ability is to move from lying to sitting on the side of the bed. Again, the patient should be allowed to do this independently as much as they can, as long as it's safe. And that's always a key factor for us in any care setting, is that we want to ensure that the patient is safe performing any of the activities that we're asking them to do. But if caregiver assistance is required because it's unsafe for them to do it themselves, we're going to be responding and scoring GG0170C based on how much assistance do they require, and we'll be going through the scoring as to how you would do that. Another important piece that we need to make note of is the use of an assistive device, and the fact that with GG0170C, the patient can use an assistive device, and that does not change the scoring at all for this measure. So if a patient needs to push off their bedside table, that could be considered an assistive device. That would not impact the scoring. If they could do that independently, you would still score them as independent. I also, with a colleague, she received home physical therapy. Her physical therapist in home care instructed her to use a belt to move her legs from lying to the side of the bed. That would still be considered independent. She was able to perform that activity. The assistive device of a belt or a strap or whatever it is that the patient needs to use to move safely independently from lying to sitting is still considered acceptable and does not impact the scoring, so they would still be considered independent in that activity. And the last step that we want to highlight for you is that the patient's performance many times can vary. So what we're looking for in the guidance from CMS is that we're looking at the patient's usual status. So we wouldn't be taking their best performance, or maybe that one time that they really couldn't get out of that lying position because maybe they had a bad night's sleep. You want to take the patient's usual performance as the scoring for this measure. So this is a screenshot of how the measure does appear on the OASIS. You can see on the top, it does give you the coding instructions for both the start of care performance, the SOC-ROC performance scoring, And then also looking at coding the patient's discharge goal and which coding items you can use for that. On the left, you'll see the coding options that you have, and we'll be going into each of those in a few minutes. And the highlighted area number 1, so this is GG0170C1, which is the yellow column that you see. That will be the score that you give for the sock rock performance. The second column is the discharge goal, and you'll be determining that at the same time. But again, you're going to be using the patient's input, your assessment, and the caregivers to score the patient's discharge goal. And again, we'll be getting into that. But the measure, and again, this is on the far right side, looking at the definition of what we're actually trying to score here, it's the patient's ability to safely move from lying on their back to sitting on the side of the bed with their feet flat on the floor and no back support. So that's really not rocket science if you try to break it down, and we just need to score them as to how well they can do that on their own or how much assistance that they need to perform that activity. So the coding instructions, we do have a 6-point scale that is pretty self-explanatory, and we're going to go through each of those. Code 6 is if the patient can perform this activity independently. Code 5 would be if they require setup or cleanup assistance. Code 4 would be supervision or touching assistance. Code 3 for partial or moderate assistance. Code 2 is for substantial or maximal assistance. And then code 1 would be for a dependent patient would be code 1. And we do have options for if the patient, we do not attempt this activity for a variety of reasons, or if the caregiver that is there to help the patient, we did not attempt the activity. Those would be code 7, which is when a patient would refuse to do this. Code 9 would be used if it's not applicable, and again, we'll get into the details of that. And code 88 would be used if it was not attempted because of a medical condition or safety concerns. So looking at the actual screenshot of the measure, you can see the highlighted area, which is the code 6 for independent. And this is, as I described earlier, if the patient can complete the activity by him or herself without any human assistance whatsoever. So there would be no caregiver helping in any way. The patient wakes up and their alarm goes off and they're able to get up from lying to sitting on the side of the bed and get their feet on the floor without any assistance. That would be a code 6 independent. Code 5 is used for a setup or cleanup assistance, and that's a fancy way of talking about a patient that really can do it pretty much independently, but prior to doing the activity or immediately after the activity, they might need some setup assistance. So an example of this would be a patient that requires a sling on their shoulder to get up, and they need a caregiver to help put that sling on. So once the caregiver goes over and places that sling on the patient's able to get up and swing their legs over and put their feet down. So that would be a score 5. Another example would be a patient that is unable to put the bedding, put their covers down at the bottom of the bed. They can't get their feet untangled from their covers. So the caregiver would have to pull down the covers, and then the patient would be able to move their legs to the side of the bed safely. Another example, which was one of the questions that had come up on the CMS site, was for a patient that can't reach the floor. My mom is like 4'10", and she can't reach the floor when she sits up. She's so cute, little Italian lady. We love her. And we would need to put a little stool on the floor for her just so she could get her feet, especially when she comes to visit me, because my bed's higher than her bed at home. But that would be a setup, so that she could do the activity safely. Again, it's not doing it for the patient. You're not assisting them other than to give them assistance for setup and then maybe remove that stool. So that would be the cleanup. And you would score that patient as a 5, just needing that little bit of assistance prior to or after the activity. Code 4 is used, and again, we're going up in terms of assistance. This would be used when the patient needs some supervision or touching assistance. So, and I know you're all picturing the little old lady in your head that you've seen, right? That, is just laying in bed and needs maybe a little coaxing, a little encouragement. You can do this, maybe putting your hand on their shoulder to just guide them, but really not physically helping them move from lying to sitting, but just coaxing them, giving them some supervision, some encouragement. This would be a code 4. So again, it's an assistance that could be provided throughout the activity, or it could be provided just intermittently or just at the beginning of the activity to just coax them and encourage them to move and get to from lying to sitting on the side of the bed. So again, it's an encouragement and supervision so that the patient will perform the activity and that you're making sure that they're safe to do that. Code 3 is used for partial or moderate assistance. And the key words here, and you're going to be hearing this for the next coding, is the amount of effort. So for code 3, the partial or moderate assistance, we're really looking at a patient that really does more than half the effort, so the caregiver is providing less than half of the effort. So the caregiver could be lifting their trunk, helping them move up to a sitting position. They could be lifting the legs a little bit to help them slide them over so that they could put their feet on the floor. But it's less than half the effort. The patient's doing more than half. So again, that's a clinical judgment, but seeing whether it's less than half or more than half is the distinction between code 3 and code 2. So I've answered for code 2, which is when the caregiver does provide more than half of the effort to move from sitting or lying to sitting on the side of the bed. This, again, the patient would be providing less than half so that the caregiver is really doing more of the work than the patient is. And this is done, again, throughout the activity. Both code 3 and code 2 are support, assistance that the caregiver is providing throughout the entire activity. This is compared to when they were providing just some cueing assistance or contact guard assistance. That could be intermittent. And the code that we talked about where you would do setup, that was really prior to and after. So code 3 and 2 they need assistance throughout that whole movement to get from lying to sitting on the side of the bed. And the last numeric code is code 1, and that is for a dependent patient. This would be the patients that we know that can't perform this activity at all. They would need 100% assistance. It would be by one caregiver, or it could be 2 or 3 caregivers that are required to get the patient from a lying to sitting position with their feet on the floor. Again, this would obviously be someone that gets this assistance throughout the activity. So the caregiver or the family member would be, really providing all of that assistance, doing all the effort for the patient so that they could complete this. So now we're moving on to the coding options if the activity was not attempted and why that would be justified and an appropriate code or score to use. So code 7 is when a patient refuses to complete the activity. I'm sure all of you have patients that participate and cooperate 100% of the time, right? That would be a wonderful world that we'd live in, but we don't, and it's home care, and we know that we have all sorts of wonderful challenges. Actually, we have that in all of our care settings. So pretty self-explanatory. If the patient refuses to do this activity, and we know that we've had those, that patient would be scored a 7, that they just refused to perform the activity. So code 9 would be not applicable, and this is really for a patient that would not have been able to perform this activity prior to the reason why we're providing home care for them. So this would be your patient that would never have been able to do this before they maybe had their knee replacement or whatever reason you're in providing home care services for them. So it wouldn't be applicable that we're in providing a new episode of care to expect that they would be able to do this because they couldn't do it before. So that would be a code of 9, and it would be not applicable. And code 88 would be if the activity was not attempted. This would be due to a medical condition or a safety concern that would prevent the clinician from performing this activity. So this would be an appropriate code to use if their medical condition really prohibited the patient from performing that activity. And the last coding option is the dash, which Ann Spinard had talked about earlier. The dash is a valid response for GG0170C1, which is the sock rock performance coding. It is a very rare occurrence that you would use the dash, and CMS would expect that you really are not using this as a frequent response. It would really most often occur if the patient was unexpectedly transferred or discharged or died prior to the assessment item being completed. So in that instance, it would be appropriate to use the dash. So some of the key coding questions that you can use to help your clinicians, your nurses decide how are they going to answer these questions. A good way to approach it would be, well, what questions could you ask yourself to help guide you in answering GG0170C accurately? So the first question is, does the patient need assistance? That would be the first line. And obviously, if you said, no, the patient doesn't require any assistance at all, then this scoring would be 6 because they're independent. If the clinician asks themselves, well, does the patient need just a setup or cleanup? Did they need that stool, or do they need some type of assistive device to help them move from lying to sitting? That would be the belt would be a 6, that would be independent. But if the patient needed setup, they need cleanup, they need the nurse or the caregiver to help put a stool down, as we described earlier, then the answer would be yes, it would be a code 5. What if the nurse could ask themselves, do they just need some verbal cueing? Do they need some encouragement? Are they just, really feeling unmotivated to perform this activity or nervous? We have a lot of our patients that, it might not be physically that they can't do this, but they just really need to have their anxiety reduced a little bit. So if you're there and you can coax them, you can help them put your arm on their shoulder, as I mentioned. If the nurse, says to themselves, well, does the patient just need that verbal cueing and that assistance? Then I'm going to score them a 4 for supervision and touching assistance. or these key questions about this more than half the effort or less than half the effort. This is a key area that you're going to need to really talk with your nurses about and help them to really internalize this way of gauging, whether it would be a score for 3 or 2. And for 3, again, as we talked about, is it less than half the effort? If it's less than half, so the patient is doing more of the effort, then the nurse would say, yes, it's a code 3. And in contrast to that would be code 2. So does the patient need the caregiver to do more than half of the effort? So again, this is the distinguishing factor between 3 and 2. And the nurses are really going to need to ask themselves this so that they can arrive at the proper code, whether it was more than half the effort. And when it's more than half, it would be a code of 2, which is indicating that it's substantial or maximal assistance, versus the code 3, which was the minimal assistance. And then the last question or coding question that the nurses should be thinking to themselves is, does the helper provide all of the effort? And I think many times these dependent patients that we really have to provide 100% to help them get from lying to sitting on the side of the bed, those seem to be the clearer scenarios. That would be obviously a dependent coding. That would be a code 1 for dependent to move from lying to sitting on the side of the bed with their feet on the floor. And then these last codes that, again, if the activity was not attempted, again, you have the code 7, which is if the patient refused. You have code 9, which was the not applicable code. So if the patient did not perform the activity prior to this current illness, you would be coding them a 9. Or code 88, which would be that you did not attempt the activity due to a medical condition or a safety concern. So we do have some coding tips, and some of these were actually created because we've been very happy to receive questions from our home health colleagues throughout the country. One of the questions, which we thought was a really great question, and I know you'll all be able to relate to, is what if the patient doesn't sleep on a traditional bed? And I know we all have those patients that like to sleep in a recliner. I know my dad was guilty of that very often. These are patients that just don't like to sleep in a traditional bed for whatever reason. It might be a medical condition, or it just might be a preference. How do we score someone that does not sleep in a traditional bed when we're trying to measure lying and moving to sitting on the side of the bed? So we did obtain guidance from CMS on this question, and you basically would be scoring the patient as they are able to perform the activity in this alternate sleep surface. So if they sleep in a recliner, you would be assessing their ability to move from the reclining position, which would be lying for the patient, and how they're able to get up and swing their legs over, get their feet on the floor, and you would code them based on that. Again, the assistance that they need to move from that other surface. I actually, in home health, we had a patient that slept on the floor on a mattress. They were safe. It was their preference. Once we got over that, and I don't know if any of you have had patients that slept on a mattress on the floor, but this was because of a back issue and they were most comfortable. But they were able to get their legs down, their feet on the floor, and get right up from that sleep surface. That would be independent. So again, there will take a little bit of judgment on this, but if that is their sleeping surface, that's what they consider their bed, you would assess the measure with the same guidance that we've talked about with the actual traditional bed. So I hope that that's clear, and we can talk about any questions if you have questions on that. So what if the patient's feet don't touch the floor? I mentioned that in the example for the setup example for the code 5, when you put a stool under the patient. But what if the patient gets up, they're able to get from lying, they're able to swing their legs over by themselves, and they're able to sit very safely with their feet just hanging without them on the floor? Is that a independent score for 6? It would be, because the patient's able to do that safely. And again, in home care, in all of our care settings, we just need to remember that the safety aspect of things. The patient's able to do that. They're safe sitting on the side of the bed. They don't need any support on their back, even though their feet don't touch the floor initially, and they scooch a little bit to get their feet to the floor. That would still be dependent, and you would score that a 6. For the patient with the step stool that I mentioned previously, again, the assessing clinician feels that the patient is not safe sitting at the bedside without their feet on the floor. I know we've all seen those patients, right? They sit up and they try to swing their legs, and then they're ready to fall back down. So a patient that's able to get their feet close to the floor, but they can't reach the floor, and they're unsteady and they're going to fall back. So by using a footstool, you would be able to make this activity safe for them. You would be able to score them a 5. You wouldn't have to be supporting them. They're able to get up, get their feet down, and if you put a stool under their feet, it would be safe for them. So it would be the scoring of a 5 for setup and cleanup assistance. So again, for last but not least coding tips, we really need to report the help that the patient needs to complete this lying to sitting transfer. And if you keep that in your mind and use that as really the driving message to your clinicians, that you're really trying to just quantify how much help does the patient require to move from lying to sitting. And again, just keep remembering why we're doing this, because it is a covariate for the pressure ulcer, worsening pressure ulcer quality measure. A patient that's not able to perform this activity, they need assistance. That is something that is a risk. It is a risk adjuster for that quality measure. So it's important that we get it right, and we're just evaluating how much help they really need to complete the activity. We do understand, and I mentioned earlier as well, that clinical judgment is required in everything that we do. I know all of you did a great job on all the scoring that Ann Spinard did with the pressure ulcers. A lot of clinical judgment that comes into play with that. And this applies as well for GG0170C, that you're going to need to use clinical judgment to make this determination with the usual status, with the amount of assistance that the patient needs. And that will help you to make the appropriate determination and the appropriate scoring for this measure. So now we're moving on to the discharge goal, which is GG0170C2. So the C2 is the second column that you can see highlighted on the screen now. And basically for GG0170C2, we're going to be scoring what we feel and what we feel after discussing with the patient and other conditions that we'll talk about. How would the patient's discharge performance look like? We'll only be using the 0 to 6 scores. So the 6-point scale is really the only scoring that would be appropriate for the discharge goal. We would not be entering 07 or 09 or 88. The patient's not going to be refusing because we're not asking them to perform the discharge activity. It's really our determination in conjunction with the patient and the family to really establish what's an appropriate goal for this patient for their end activity to be able to do this at discharge. How would we score them on discharge for this measure? So some of the coding instructions for this, and again, I'm sure this is not new measures, new information for you, that the clinicians would really need to be considering various factors when they're trying to code GG0170C2 for the discharge goal. You'd need to really consider the patient's medical condition or conditions. So is that going to impact how well they're going to progress at discharge in getting from this lying position to sitting on the side of the bed? How about the expected treatments that we have? What are our orders? What are we providing in home care? And do we feel that the treatments that we'll be providing is going to get the patient to a better place or possibly not? So that's part of how we're going to be considering what the appropriate discharge goal score would be. What is the patient's motivation to improve? We talked about the patient that refused to do the activity. We have all varieties of patients in terms of their motivation. So we need to take into consideration in talking with them and observing what their motivation is to improve from where they are today at the sock rock performance, and where do we feel based on all of these factors will they be at the time of discharge. We also are looking at what their prior self-care and mobility status is. Obviously, that's a key issue as to how much better, how much improvement can we expect based on what their prior level of function was. So that will obviously be something that's going to impact the discharge goal. And then looking at whether there are current multiple diagnoses that could be impacting the scoring as well. So again, we can't stress enough that the importance of getting an accurate goal is looking at all of those factors, but also having a very frank discussion with the patient and the family, the caregivers, to really determine what is the appropriate discharge goal for this patient when you're there at the sock rock, at that start of care or the resumption of care. Where do you expect that patient to be at the time of discharge for this measure? So the use of the dash for the GG0170C2 is an appropriate or a valid response. Again, we have to stress that it would be something that would be rarely used. It's valid if the patient unexpectedly is transferred or discharged so that you're not able to complete this assessment at that time. So you would be able to use the dash, but again, it would be a rare time that you would use dash as the code for the discharge goal. So what would be the scenario that your nurses would determine that the discharge goal is higher than the sock rock performance? We'd like to think that all of our patients improve. Sometimes there are reasons why the score would not be better. But in the instance where the discharge goal is higher, it would be that the clinician has determined with the patient and the family that the patient should be expected to make functional progress by discharge, and that the response reported for the discharge goal will be higher or more independent than the sock rock performance response. So if your initial sock rock performance was 3, and you felt that the patient would be independent at discharge, that would be an instance where you would have an improved or higher score on the discharge goal versus the start of care performance code. The discharge goal code being the same, there are instances that when your nurses, the clinician talks with the patient and the family, they determine that due to the medical complexity of the patient, that they are not expected to make progress during the home health episode, that it's expected that they're going to maintain that level of function, but because of the medical complexity of their condition, it's determined that the patient's score at the start of care or the resumption of care for this activity is not going to improve, but it's not going to get worse either. So in that instance, the discharge goal would be the same as the SOC-ROC performance code. And there are some instances that, unfortunately, a patient's discharge goal would be lower than the SOC-ROC performance code. This would be when the caregiver and the family, other members determine that the patient has a progressive neurological dysfunction, a condition that would be expecting that the patient would be rapidly declining because of that condition. In that instance, we would be providing skilled therapy services, skilled nursing services, possibly to slow that decline. But when you're considering all of the factors and trying to score GG0170C2 as a discharge goal, you would not say that the patient's going to be improved or stay the same. Because of that neurological condition, you would determine that the patient is going to be at a lower scoring, again, moving from lying to sitting on the side of the bed. So in that instance, it would be a lower score than the start of care or resumption of care performance. So we're getting to the fun part now. I know you guys love these practice scenarios. I was watching you all with Ann Spinard's practice, and you all did a great job. So again, we invite our listeners that are online to please take out a piece of paper and participate in our practice scenarios. This is really where the rubber hits the road. We can talk about concepts all day, but it's really important that we practice this and try to be sure that we can get this right when we're teaching our nurses how to score this very important item. So the first practice scenario is about Ms. A. Ms. A pushes up from the bed to get herself from a lying to a seated position. I think people are looking for a scoring sheet. Is that what you're looking for? Yeah, I'm sorry. So there is no scoring sheet for this. You can just take notes on a piece of paper. And we're going to be using the polling questions, so there is not a scoring sheet like Ann Spinard had. So you're off the hook. You don't have to do heavy-duty homework, just a little bit. So I'll start again. Ms. A pushes up from the bed to get herself from a lying to a seated position. The caregiver must provide steadying or touching as Ms. A scoots herself to the edge of the bed and lowers her feet onto the floor. So how would you code GG0170C1? Wow, that was great. And what would your rationale be? Yep. So I heard a couple of answers. There was, again, the Ms. A pushes up from the bed to get herself to a lying and seated position. The caregiver provides touching assistance. I did hear 5, and I heard 4. The actual coding would be 4 because the caregiver is providing supervision or touching assistance. So 5 would be just that setup, either before or after. So this is a tricky one that you want to just understand the distinction there. So Ms. A required that steadying, the touching assistance in order to safely complete the task. to move from lying on her back to sitting on the side of the bed. So this next scenario is going to be one of our polling questions. This is about Mr. B. He pushes up on the bed to attempt to get himself from a lying to a seated position as the occupational therapist provides much of the lifting assistance necessary for him to sit upright. The OT provides assistance as Mr. B scoots himself to the edge of the bed and lowers his feet to the floor. Overall, the OT must provide more than half of the effort to complete the task. I'm hearing a lot of twos. Any others? So please use your polling device on the table. So again, we have A would be code 4 for supervision or touching, code 3 for partial moderate assistance, code 2 would be for substantial or maximal assistance, and code 1 was for dependent. And we see the majority of people scored or chose C, which was 2 for the substantial or maximal assistance, and that is correct. So code 2, the way the scenario described, Mr. B required the caregiver to provide lifting and assistance that represented more than half of the effort. And again, that was the distinction that we talked about. So when I look at the scores, it was really divided between coding for 3, which is less than half, or choosing code 2, which is more than half. So this is a clinical decision and determination that the nurse would apply as they're watching and observing the patient, and how much assistance did they require. In this case, Mr. B, again, required assistance that was more than half the effort to complete the task, so that would be scored as a 2. So the next practice scenario is Mrs. Y. Mrs. Y is obese and recovering from surgery for spinal stenosis with lower extremity weakness. Oh, I'm sorry. Thank you. So Mrs. Y is obese and recovering from surgery for spinal stenosis with lower extremity weakness. The caregiver partially lifts Mrs. Y's trunk to a fully upright sitting position on the bed and minimally lifts each leg toward the edge of the bed. Mrs. Y then scoots toward the edge of the bed, placing both feet flat onto the floor. She completes most of the activity herself. So how would you score for Mrs. Y? And again, this is a polling question, so please use your devices. So code 4 is for supervision or touching assistance. You choose B if it's code 3 for partial or moderate assistance. You would push C for code 2 for substantial or maximal assistance, and choose D for O1, which would be dependent. And the answer we have, we have 82% that chose B, which was code 3, which is correct. We had 15% that chose code 2, which is the substantial and maximal assistance. So again, it's that deciding factor between the less than half or more than half of the effort. When we look at the rationale as to why the correct answer was 3, Mrs. Y required the caregiver to provide limited assistance. That was a key word there, so it was limited or less than half of the effort. It was more than providing verbal cues or touching or steadying, but it was less than half, so the proper code would be that partial or moderate assistance, which would be a code of 3. So our last scenario, it has 2 parts. Mr. W states he wishes he could get out of bed himself rather than depending on his wife to help. At the start of care, the patient requires his wife to do most of the effort. Based on the patient's prior functional status, his current diagnoses, the expected length of stay, and his motivation to improve, the clinician expects that by discharge, the patient would likely only require assistance helping his legs off the bed to complete the supine to sitting task. So this is a polling question, and we're going to answer the first part of the question. How would you code GG0170C1? So this is the sock rock performance coding. How would you score for the patient? Would it be 04, that it was just supervision or touching assistance? Would it be code 3, partial or moderate? Would it be code 2, substantial or maximal assistance? Or code 1 for dependent? You think it's 1? Okay, so we got a variety of answers on this one. The correct answer was code 2. And the description in the scenario was at the start of care, resumption of care assessment, the wife did most of the effort when they described this, so it was more than half of the effort for the wife, and we'll be describing the rationale a little bit, but that is why code 2 was the appropriate answer. And for GG0170C2, so this is for the discharge goal. So you're there, you're at the start of care, the resumption of care. And as you remember, we described in the scenario that the patient's prior functional status and considering all the factors that he expected that the patient would only require assistance, would likely only require assistance helping his legs off the bed. So this is a polling question. Okay, so it looks like everyone's completed that. So the correct answer, again, this is for the discharge goal. This is for GG0170C2, that the patient would require the discharge goal after assessing all of the factors would be 3, that it would be partial or moderate assistance, because as described, the patient would only require assistance helping his legs off the bed. So looking at that scenario, just reviewing again the coding, and it takes a little bit to practice this and to think through the different steps in coding this appropriately. Again, for GG0170C1, it would be coded as 2 because he needed his wife to do more than half the effort to get up and get his legs onto the side of the bed. And then for the discharge goal, it would be coded as a 3 because they felt that it really would only be that the clinician and the patient expected by discharge that he would only need the caregiver to assist, providing less than half the effort to get his legs from a lying position and to get sitting on the side of the bed. So in summary, we've talked a lot about the importance of the covariates for this quality measure for risk of pressure ulcers, and GG0170C is a risk adjustment covariate for pressure ulcers that are new or worsened quality measure. It's also a brand new item. I know that you all know that now. It's added to the OASIS-C2, and it does require observation and assessment, and is one of those items that will be measured across all settings as described and required by the IMPACT Act. It also assesses the patient's usual assessment using that 6-point scale and also those 3 activity not attempted codes. And the dash value, which is a rare occurrence to use, it still is a valid response for this item. And Ann Spinard did a great job of talking about how important it is to take this information and use it as an action plan when you go back to your staff. As seen by the answers, this does take practice. As they say, practice makes perfect. It is a new item, and it's something that we all need to work on and practice. And your action plan really should be looking at your workflow, your processes. How do you need to revise them to reflect the addition of this new measure? And what education plan? Ann Spinard mentioned using SurveyMonkey or using a Blackboard platform, whatever it is that you use to educate your staff. But again, putting in place an action plan because evidenced by your responses here today, it is going to take some time so that the nurses are able to score this correctly. And then looking at an annual performance improvement plan, because as we know, OASIS proficiency is not a one-time thing. It's something we need to work at consistently, and integrating this into your annual performance improvement plan would be a really key area to make sure that your initial education and work is efficient and accurate so that your scoring is the way it should be. You've seen these resources from several speakers prior to me, so I don't think I need to read them, but just suffice it to say that there is tremendous amount of information out there, so please know that the resources are there. So I think we're pretty much out of time at this point. So we're going to hold questions for later, but I do thank you for your attention and thank all of the listeners that are online. Again, this is a new item, but we're really hopeful that you're embracing it as a great new item to look at this as a covariate and accurately measure this across all settings.